So, welcome to another episode of 22 at the Lips. This is the podcast from EMS providers to EMS providers and healthcare providers and anybody and everybody in between. Whether you are in EMS, whether you are not in EMS, thanks for joining. Um, on the podcast, obviously, if you've listened to any other episodes, and if not, here's my little spiel. I have on people to interview and talk to and discuss different topics related to the healthcare profession. And I try to get it more of not so much just EMS, but also different aspects in this field that we encounter, and just general things of the healthcare system in general. And one of those that I want to talk about today is hospice and what it entails, what it means, what it relates to in the emergency responder aspect, kind of debunking a couple of myths and bringing out different aspects of hospice that either we may not know about, whether it's something that we're told and we believe, and it's like one of those, like I said, those myths that don't really have any validation behind it. But to have someone on that knows better about this than myself, I have Miss Bobbie, and she works in the hospice setting. I'm gonna have her introduce herself, tell us what she does, and we'll go from there. So, Miss Bobbie, if you want to tell the people who you are, what you stand for, go ahead, sis.
Okay. So I am a registered nurse. I have been a registered nurse for probably 25 something years. And I have started out in the operating room, loved the operating room, thought I would stay there forever, and then was introduced to hospice. I have two grown sons. One is a lieutenant in the Livingston Parish Sheriff's Department, and the other is a market share owner of a window company in Denver, Colorado. I have two 5-year-old grandchildren and a new one on the way in February. I have recently been able to retire to get to spend more time with my grandchildren, although I am still doing some consulting work with Bridgeway Hospice, which is the hospice company that I helped start out almost 12 years ago with my business partner, Dana McBride. So I still, hospice is my passion, it is my calling. The very first day that I started hospice, I realized that this is truly more than a job. It is a calling and it is my passion. And I still have that deep love for it and will, although I'm not currently actively working in the hospice, setting, I am still providing guidance and consulting work with the company that I helped start over 12 years ago.
So tell me this real quick. One, congrats on the new grandbaby coming on in.
Thank you.
Um, what made you want to go from working in the OR setting to hospice? Because that's a little bit of a jump.
That is a little bit of a jump. So one day, one of my coworkers that worked with me in the operating room told me she was leaving to go work for hospice. And I said the same thing to her that everybody says to me, why do you want to do hospice? All your patients die. And she said, it's a new company. And I actually thought she was a little crazy because she was a single mom. She was going to work for a brand new company that had just opened in Baton Rouge. And I'm like, oh, that's kind of, I'm used to the security of the hospital setting and, knowing for sure they're going to be there tomorrow. I said, but when you get there, if you like it, call me. And about 6 weeks later, she called me and she said, I have the perfect job for you. So I prayed about it before I went. And I said, my kids were little. One of them wasn't even in school yet. And so I said, I wanted to be able to bring them to school. The operating room did not allow that. I didn't see the light of day, after I got to work. I didn't know if it was raining, sleeting, snowing, or what. And so I wanted some more flexibility with my family and to be able to bring them to school and, so, and of course, salary was one thing. And I was working at the Baton Rouge General Mid City. So if I was on call, I was working. So I was missing a lot of time, family time. And so I went in and interviewed, and everything that I had prayed for, she answered in the interview. So I accepted the job on the spot, and it was an admissions coordinator. So I would go out and meet with the patients and the families at the beginning and tell them what we could do and what we could offer them. And it was so rewarding to see these families because most of the time, by the time they finally agreed to hospice, they are exhausted. They need the help, they need the resources. And it was so rewarding to be able to go in there and tell them, you know, we can do all of this and Medicare pays for it at 100%. So you don't have to pay for anything out of pocket. And so many people are afraid of hospice and put it off, and just the stigma, the negative stigma that comes with hospice, that when I would go in and talk with them, they were like, "Oh my gosh, I didn't know that you could do this." And one of the most common things that I hear is, "I wish I would have done this sooner." And once they realize we come in and we start helping in what we do, they realize that what a valuable service it is.
100%. And kind of like I talked to you about before, I've had a few family members like that got put on hospice. I don't know how else to say that, but they got put on
Mhm.
hospice. And just especially now being in EMS, just the vast difference of their ability to pass on and the comfort of them being in their home and
Right.
with their loved one, like with us and their loved ones and stuff like that, versus how we see it as these people pass away and either we're rushing them to the ER and then they get put in the hospital and they get put on vents and drips and there's no peace in a hospital. There's no it's kind of an ironic thing of you go to the hospital because you're sick or whatever and you need to rest, but there is no rest. And so
There is not. I often say it, the hospital setting is not conducive to healing. And
right.
it's just not.
But
Oh,
there's just that vast difference. And I wholeheartedly respect and appreciate the hospice system. But just if for the people that don't know from your perspective and like your obvious expertise in it, what what is hospice and what does it mean when someone goes into hospice? Like who qualifies for hospice? What's like a general rundown?
so the definition of hospice is if your disease process takes on a normal progression rate and there's a 50% chance of mortality in 6 months, then you qualify for hospice. So it can be any disease process. Some people think it's just cancer or it's just, they don't realize that like Alzheimer's is a life-limiting illness. It does cause someone's demise. So we take care of patients that, stroke, kidney patients, heart, lung, and of course, cancer, Alzheimer's, anything like that. So once and Medicare has set forth the criteria for these disease processes that when they meet the certain criteria of that disease process, 50% of the people that have met that criteria passed away within 6 months. So that's what sets the criteria that they qualify for hospice. So they do have to have a terminal diagnosis or a life limiting illness. And then they have to have two physicians that, will certify that they are terminally ill. We have to have a physician's order in order to admit them to hospice. Most of the time, the patients and or family elect to use the hospice medical director than their attending physician once they are admitted onto the hospice program, just because one, that's that doctor's specialty. And two, we have access to that doctor 24/7. So it's not like when you call into the doctor's office and you have to wait all day to get a return call from the doctor. We can, we have access to that our doctors like immediately and can get things much quicker. And most of the time the attending physicians prefer that too, because we do have access to that help and support right away rather than making the patients wait. Um, the um, the process for admitting a patient to hospice or them being admitted onto our services is we receive the referral from the physician or from the order from the physician, and a family member can seek out that referral. They don't have to wait for the physician to say, "Hey, I think it's time for hospice." The family member or patient can say, "Do you think it's time for my loved one to have hospice?" And then the physician can then say, yes, I do, and send the order over. So a lot of times that's another misconception. Well, the doctor hasn't mentioned hospice. And that's not necessarily, it doesn't mean they don't qualify. It just, maybe they didn't think of that, or they don't want to bring it up, because they don't want to feel like they're giving up on their patient. But a lot of times our patients actually, and there's studies out there that the patients on hospice actually may live a little bit longer than patients not on hospice, especially like your heart patients and lung patients, because we are in that home routinely, we're getting to know that patient, and we're catching things before they get exacerbated to the point that they need to go to the hospital. And especially like with Alzheimer's patients, when they go to the hospital, there's such a huge decline in them because they're out of their normal environment, and it just throws them off kilter. So they go to the hospital and they get thrown off. Then they come out of the hospital and they get thrown off again. We can help keep them in their home, in their normal environment, and catch those symptoms and things before they get to the point that they need to go to the hospital. I think it just improves their quality of life so much. And it's so much less stress on the family. The family doesn't have to go sit at the hospital, or, make arrangements to take care of if there's other loved ones at home they're taking care of, or whatever.
Absolutely. I like the part that you added about the different routine and stuff like that, because it's a good point. And we see it in nursing homes and stuff like that, that these patients with these terminal illnesses and cognitive health issues and stuff like that, like Alzheimer's and dementia, they, like you said, it just throws them off, and it
It
sets them
does.
back so much further because they're used to one specific routine, being taken care of one specific way, and then they're in our care, and then they're in the
Right.
hospital's care, and it's a different environment, and that's just not conducive to their condition.
Right.
Yeah. Um, One thing that surprised me, I think it was maybe 2-ish years ago. Yeah, 2-ish years ago. Um, One of actually a guy that I worked with, him and his wife found out that I think she was just a few months old. Their baby had a very terminal illness, and it was like a metabolic type of thing. Nobody could have seen it coming while they were pregnant. Whenever she was born, it's something that just felt like it happened out of nowhere. And he told me one shift that he put his baby on hospice. I was like,
Mhm.
bro, she's a few months old. I'd never heard of that, and I didn't know that was a thing. So
Yeah.
it's been very eye-opening getting like this other aspect of hospice versus, and this is dark and morbid, but like versus what we're used to seeing with like these older patients who are
Right.
coughing all the time, they're always in pain, they're drooling and all this. It was just a very different aspect. And
Mhm.
even as I kind of want to bring up, like some of the calls we go to for these patients that are on hospice, just because like they're still with it, but there's something going on and the family's freaking out, but it's not your typical like what you picture when you think of a hospice patient, just like on their last
Right.
leg or anything like that. Um,
And I have a lot of people sometimes will say, "Oh, well, they're still, say maybe a cancer patient or a heart patient, well, they can still get up and walk around." I'm like, "Yeah, just because they can still walk around doesn't mean they don't qualify for hospice. And
right.
it's what's going on with their disease process, and they may be walking around today, but next week they may not be, or next month or whenever. But so there's a lot of stigmatisms that come with hospice, and there's a lot of negative things that come with hospice that people, you know, myths and rumors. And so I like to meet with families and dispel those. And first off, ask what's your questions and what do you know about hospice, first of all, and then go in to explain what we can do. And one of the things you had mentioned previously was, you know, that they can't ever go to the hospital. Well, we can't ever really take away a patient's rights and say that they can't go to the hospital. They always have the right to change their mind. However, our goal is to keep them out of the hospital, because going to the hospital is not always conducive to healing and getting better. So Medicare allows, pays hospice to take care of these patients in the home. And the goal is to keep them out of the hospital. So we always tell our patients, call us first. Let us come out and assess, because there may very well be something we can do right there in the home, that they can do in the hospital that we can treat, and they don't have to go to the hospital. But if they don't call us and give us that opportunity, then, they don't know what's available. And it's hard. We go in and we tell these people, we become your new 911. Don't call 911, when their whole life they've been told call 911. And
Right.
we're going in after the first meeting and expecting them to trust us. So sometimes it does take, sometimes they will panic and call 911, or they'll have a family member that wasn't there at the beginning and doesn't know they should call us first, and or they panic and, oh, well, I just forgot and call. But I always say, even like with EMS workers, always, when they know they're on hospice, have you notified the hospice provider? Why don't we call them and see what they can do? Because we may very well can do something and prevent them from that ambulance ride and, that transport and sitting in the ER, and can take care of them right there, and not have to go through all of that.
And I'm not going to say it's frustrating because it's our job, et cetera, but it's a different emotion when you get called for, we'll say shortness of breath. You get called for shortness
Mhm.
of breath and you get there, and 9 times out of 10, it's exactly what you're saying. It's the family member who wasn't there for the hospice meetings and wasn't there for the whole process. They just show up, and Meemaw, who has end stage COPD or lung cancer, whatever, is short of breath and XYZ, whatever. And she calls because she's like, well, she needs to go to the hospital. And then we have to look at her and be like you said, have you called your agents? Have you called your nurse? Have you called these
Right.
people? Because, and tell me if this is wrong or not, but if it's a symptom or something related to why they're on hospice, doesn't, and this is maybe that ignorance thing, doesn't their hospice get taken away, or like don't they get put off the
Well,
list?
the patient has to elect to revoke at that point and give up the hospice benefit. So the patient or family has to decide, do I want to seek aggressive treatment, or do I want to stay on hospice? So if they choose that they, we can't take it away or make them, but it's a patient family choice. But they have to choose at that point to give up hospice or not. Now they can readmit, but they can't keep going back and forth. At some point we have to say, okay, if you keep going to the hospital, we're not going to be able to keep readmitting you. And no other hospice is going to want to do it either, because they're going to look and see that they've been on on a hospice 3, 4, 5 times. If that's their behavior, they're going to keep doing it. Another hospice is not going to want to admit them either. And the hospitals, truly, once they go on hospice, the hospitals don't want them to come back to the ER,
Right.
because, they have done their part to make the referral or get them established with hospice. The hospitals are like, you need to stay home and let hospice take care of you, because we really can't do anything else for you here. And sometimes the hospitals get a little frustrated with us, because it's like, can't you take care of your patients? And it's like, well, we're trying, if they call us, we try. But and sometimes, the family just feels like, I've got to, they actually, Medicare dings them and cuts their pay for frequent people coming back to the ER or coming back to the hospital. So they're really trying to focus on, helping keep patients out of the hospital. But sometimes they panic, and we get that, and I say that. I get it, because, for years you've been told call 911, you panic, you do it. But call us as soon as possible. And if we can try to, or like the EMS workers, when they get there, encourage, have you called your hospice? Have you seen, is there something they can do? Because there is, and like you use the shortness of breath, we can absolutely come out and do some treatments and do some things and probably alleviate it and eliminate an ER visit.
And you hit the nail 100% on the head. And it's those settings where the family member freaks out. And especially in a setting where it's your loved one, and in the back of your mind, you already know, like, they're down this path. Like,
Right.
there's realistically only one end result when they're in the hospice setting. But I mean, nobody wants to have that feeling of like, my loved one is dying in front of me in a very distressed situation versus how this is supposed to go in their mind. And so, like, I get it. It's the panic. And I
Yeah.
would say almost every call that we've had where someone's loved one is in hospice, we get there and we explain to them, like, look, you need to call your people. We've had situations where we just give the patient some oxygen and then they get better, but we try to educate them, like, hey, number one, no offense. And if there's a better way to word this, please let me know. But we tell them, like, your loved one is on hospice. They have opted for this. Y'all have had serious conversations about this. They are going to pass away. But number two, and like we educate them, if we bring them in and it's deemed as something not related to their illness, they may get hospice taken away in one way or another. And it's just, you're going to have to reapply to have all this. And it's a whole process. And
Right.
it's hard. But it happens. And we also, if you want to kind of chime in on this, it's hard whenever we have that hospice patient who has passed away and the family still calls and they're like, my mom is gone, or, my dad stopped breathing, this, that, and the other. And we get there and it's a hospice patient. So we're like, yes,
Yeah.
yes, they have.
I know. And, I'll explain to families, and sometimes I am, well, all times, I try to be brutally honest. So many people don't really understand what they see it on TV. It's not like it is on TV. And I'll say they don't go poof, poof, and your heart starts beating again. It's very traumatic. They're going to put you on the ground. They're going to, probably break a rib, puncture a lung, especially, our little frail patients at the end of their life. And the likelihood that they're going to survive it, they probably aren't. And so I ask them, is that how you want to see your mom or dad or loved one at the very end of their life, on the ground with somebody beating on their chest? And it's probably not going to have a good outcome anyway. Or if they are able to get them back for a little bit and they put them in the ambulance, they pass away in the ambulance. Wouldn't it be better that you're around, like you said, the family around the bedside, holding their hand in a very more comfortable setting, and, passing in the comfort of your home, and being able to be there? It's going to be a much less traumatic memory for them, than seeing that happen at the very end. And unfortunately, I have seen it happen too many times. Um, they panic and oh no, I can't give up. I have to do everything. And they either pass away, during CPR or in the ambulance. And it's just not a good memory.
Right. And those instances are so, I mean, I wouldn't say like it's hard on us, but it hurts a little bit just because
Yeah.
they tell us like they were on hospice. And I mean, we have to look and be like, do you have a DNR? And sometimes they say no. And so it's in the back of our mind. We're like, oh God. Like, and
Yeah.
then, like you said, it's these frail Meemaw and peepaws who
Right.
we're doing chest compressions, we're starting IVs or drilling them, and it's all this stuff. And in the back of our mind, number one, these poor people that we're doing this to. Number two, it's knowing that this patient would not have wanted this, but because of
Right.
these extenuating circumstances completely out of their control, like
Yeah.
we don't have a choice. We have to
Right.
do the thing. And That's why
And I know
anytime.
a lot of times people will say, well, how, or physicians will say, well, how can they be on hospice and they're a full code? Like that doesn't make sense. But, you know, there's no rule that says they have to be a DNR. Would we prefer them to be a DNR? Absolutely. Is our ultimate goal to get them there? But just because they're not ready to sign on that dotted line doesn't mean they don't meet criteria. They still need the help, they still need the care. And so we just provide extra education with our nurses and social workers, to hopefully get the families where they understand and are willing to sign that. And a lot of times, like you said, the patient doesn't want it. The patient's good. It's the family that feels like they're giving up on them when they're really not giving up on them. They're just letting nature take its course. And I think one of the biggest misconceptions about hospice, I wanted to say this earlier, one of the biggest misconceptions is that we hasten death. That hospice hastens death, or we come in and we give that morphine and they die from the morphine. And that is not true. We don't hasten death. We and like I said, we actually, some patients live longer because of them being on hospice, because we're preventing, catching those things before they're exacerbated. But I will explain to people that that morphine is the very same morphine that they received in the hospital when they got in a wreck or they had surgery, and I'll say, did you die when you had that morphine? You didn't. It's the same morphine. It's just in a different strength. It's a little bit more concentrated, so they don't have to take as much. But most of the time that we give that morphine, they're breathing, 30, 40, 50 times a minute. And that's putting so much stress on the body. It's like running a marathon. And I'll explain to families, you try to sit there and breathe 20, 30, 40 times a minute, you can't do it. It's going to wear you out. And so we need to slow those respirations down. We need to get them more comfortable so that they can, not, it's putting so much more work and stress on the heart, and the whole body when they're breathing like that. And so it's not hastening their death, it's getting them comfortable to where they can pass peacefully, but it doesn't, stop their breathing. I mean, if you give too much, obviously, yes, you can, but it's in controlled doses and in a controlled environment, and it does not, you know, hasten death. And so many people think that and are afraid of that, but it's such a wonderful drug and can be used to help alleviate so many symptoms.
And at the core of it, it's that comfort care of, I mean, this patient signed up to have a more peaceful path of passing
Right.
on. And so,
Yep.
I mean, shoot, sign me up, put me on some morphine. No, I'm just kidding. um, what would you say? So we kind of talked about some misconceptions of hospice in general. What is something else that you encounter that people either think about hospice or whenever their loved one is in the system of hospice that is so vastly different from reality?
Um, I think that they think that we're going to come in and we're going to stop all of their meds. They're not going to have any rights. We dictate everything for them. And so one of the things that I will tell patients is, you know what, this is your ball game. You're the coach. You're calling the shots. And it is a collaboration of care, and every patient has an individualized plan of care that we will talk and on admit discuss what are their needs, as far as, do they need a CNA, do they want the chaplain to come, do they want the social worker to come, and all of these people bring together, um and it's a team of people taking care of this patient and family, and it is about them. And we anticipate as they decline and things go on, our visits are going to increase and we're going to come more. But we don't go in and automatically stop all of their meds. Now, we may recommend that they don't need to be on as many meds, or, the risk outweigh the benefits at this stage in their life. So we may do some education like that and make recommendations that this medication really may not be indicated at this point in your life anymore. But it's a discussion with the patient and the family, and it's ultimately their decision if they wish to stop them at or not. We're going to provide the education, but so many people think that we just come in and stop everything and, just basically give up on them. We're not giving up on them. We treat them every single day and take care of them, and we're going to treat their signs and symptoms and things that happen. We're just not throwing in the towel on them. And I think that's probably one of the biggest misconceptions.
Right. Because like we talked about, it's this picture of somebody's on hospice and everyone knows the end result. So like you talked about, I've been in those shoes to be like, oh, well, they're just going to stop doing everything. Why would we do that? But it's not that. It's the
Right.
continuation of care until the end result, but doing it in a manner that most benefits the patients, and gets them to, that brings them to that end result that they're going down, but in a more comfortable way and more conducive way.
So I often refer to and explain it to families that the dying process is very much like the laboring process or the birthing process. And that patient actually labors. They do things and go through things, to prepare themselves and their bodies for that next realm, whatever their belief system may be. And they are actually laboring into a different realm, and they are essentially getting the ultimate healing. Their body will be healed, and go into that next realm. And I know everybody has different beliefs, and so that's what I say, whatever their belief system may be, but it's actually very similar to the laboring process. They're just laboring into that different realm. And sometimes when I explain it to families like that, it's kind of like, oh, well, I never thought of it that way, but it truly is very, very similar to that. And then also another big misconception is that they're starving to death, because you know, we don't do IVs, and they're like, well, can't you give them IV? They need to have fluids. But actually, I'm a spiritual person. God has thought this all through and has divinely planned this and made the body to where it doesn't need that at the end. And the patients will actually clamp their mouth down and they don't want it. And so I always tell families, if they want it, give it to them. But if they clamp their mouths down, don't force it. And it is a very much more peaceful death. On the patients that I've seen at the end, that the families don't force fluids and don't keep trying to put ice chips and put water, because what goes in has to come out. So the more that's going in, the more work that they're actually putting on the body. And the body is designed to, at the end, not to need that. And they're truly not starving, and the calcium levels at the end of life, when they're going through that, not taking the fluids in, and I can't remember if it goes up or down, but whichever way it goes, it actually kind of makes them slip into a little coma. And when we ask people, how would you like to die? Most people say, well, I'd like to just go to sleep and pass away, not wake up. When we don't push those fluids and it kind of encourages that our body to do that, and not, and they're able to slip into that coma and pass away more peacefully. But so many people, well, I'm starving them to death. And especially here in the South, because we think if you're sick, you got to eat, you got to feed them to get well. So that's a very hard thing for families to grasp and understand. Not giving them fluids, not giving them water, not offering food, but really and truly, it's a much more peaceful death. And I'm sure you've heard the death rattle, and people have heard the death rattle. The death rattle is not uncomfortable for the patient, but it's uncomfortable for the family to hear that. And if they don't have the patients that have less fluids and less intake at the end, the death rattle is not as prominent. So it's more comfortable for the family to not have to hear that as well.
100%. On that note, the body makes a lot of noises when it's passing on and when it has passed on. So there's some things you can't unhear. That's definitely at the top of them.
Right. Yes, for sure. Once you've heard that death rattle, you know it for sure.
Um, I think another hard thing is I feel like this is whenever we get called to these patients is when someone is in like the very final stages of life. They'll decline as they do. Um, and especially while they're in hospice, like it is that gradual or sometimes sudden onset, like just very sudden decline, and then out of nowhere they just pop back up. They just and then right after that is the decline. And so we have these families that they'll call because they're like, well, they were doing just fine, they were getting better, and now they're back down. And we have to explain, like, for whatever reason, this happens.
Well, that's what I was referring to with the laboring process. Very much like a new mother has a nesting phase. She gets that burst of energy right before that baby's born. It's kind of the same thing. They get that burst of energy right before the end is near, and so they'll, perk up. And, I had one little lady that she was up cooking gumbo, the day before she passed away. And the family's like, oh, and she had been in the bed, like not doing well. And that last day before she passed away, she was in the kitchen cooking gumbo. And they're like, oh, she's healed, she's better. It's like, oh, I try to educate this. It could just be a little burst, that last hurrah. And a lot of times it is, but it gives the family kind of a false hope or a false sense sometimes too.
Right. And I know I wouldn't say all, I'm not going to speak for all agencies, but most private ambulance agencies, like the one I work for, we will transport a patient either from the hospital or a nursing home back to their residence on hospice. And sometimes we see them in a very uh, not good state and they're going back. And so it's kind of this very somber setting and stuff. But then we have a couple that like the patient is it seems totally fine and everything's great. And I've kind of learned from one of the partners I had that if they're going home on hospice and they're doing great, pull one of the family members to the side and just kind of explain, like, hey, I know they look great. I just want to warn you guys, as you know, your family members on hospice, just this could be that last burst of energy. Just,
Yep.
while I've told patients' family members, while they're feeling like this and while they look like this, say what you need to say because
Right.
this could be it. And I've had a lot of people that kind of receive that well, and they're like, you're right. Thank you for telling us. We've been told that, whatever. But like those calls where the panic families, it's also just as hard because I don't know, from one perspective, it's from the outside perspective, it's hard to see it like you're putting your family member has decided to do this and you're putting them through this because you have the same end result. How do you not know? But then at the same time, like, I've had to tell one of the people I've worked with, like, hey, look, even though we don't understand and it's frustrating. Like one time we had to transport this family member on hospice because the family was freaking out. The patient was at the point where they couldn't speak for themselves and they couldn't say what they wanted. And the family member knew they could possibly lose that spot in hospice and we had to bring them anyways. Um, and the girl I was working with, she was livid because she's like, why? What is the point? So they can die in the hospital. I was like, look, if that was my mama or if that was my dad, my brother, sister, I can't say I wouldn't panic, but I mean,
And,
it's a
and
hard thing to grasp that
it
like
is.
it's hard. And so it's
And sometimes those families feel like, I have to, do this one. I just have to make sure there's nothing else to do, or I have to just be sure that I'm doing everything that I could possibly do.
it's frustrating. It's hard, but also having that empathy because that's I mean, like I've said, it's the same end result, but at the same time, you still see your loved one in that situation. Um,
Right.
so in that note, I know we try to give a lot of compassion and empathy, like I said, but besides just telling like these family members, like, hey, have you called the hospice agency? Have you done this? what could be some things that would warrant transport to the ER? Because we showed up one time. Um, this elderly lady had fallen. She had a, I mean, we can't diagnose in the field, but she had a broken leg. And
Right.
so we were trying to, the family members like, can't you just splint it and leave her here? We're like, oh, I mean, we could, but her diagnosis is Alzheimer's. Like, I mean,
Right.
have you called your agency to see if they could
Yeah.
bring her to the hospital and like help fix that a little bit? And they're like, well, we don't want to lose hospice. I'm like, okay, but broken leg versus Alzheimer's.
Right. And so I've actually had some patients, so we can do x-rays in the home. So we have a contract with a company that will come out and x-ray in the home and show, if there is a fracture or not a fracture or whatever. And so I will often tell families, I can't fix a broken leg in the home, obviously. So that may be something that is truly a warranted reason to revoke from hospice to get treatment for, because it is not related to their hospice diagnosis. However, you know, if you want to have it fixed. I've also had some families that elect not to have it fixed because they're like, they already fell once before and they wouldn't put them under anesthesia. And, you know, at this point in the game, she's already in the bed and can't get out of the bed, and they don't want to put them through it. They don't want to, but we can't make that choice for them. That has to be a family decision. So we can give them the option of that. It's up to you. If you choose not to have it fixed and not to have treatment, they can make that choice. But we can do an x-ray and determine, yes, it is fractured, no, it is not fractured, or whatever, but then the family has to make that choice at that time.
I feel like a lot
And
of
the goal
times.
still
Go ahead.
remains on comfort. The goal still remains on comfort, obviously.
100%. And that's the goal of hospice.
Yeah.
Um, I'm trying to think. I think that's a lot of the general questions and points.
Yeah.
Oh, so somebody that's listening and they're considering, um, I don't want to say considering putting their loved one on hospice, because that's something that the patient and the family have to come to consideration. But um, what would you say are for like the final point, more or less, what would you say are the biggest drawbacks and slash or like the pros and cons to having your loved one in hospice? I mean, we've already mentioned a bunch, and I kind of gear this episode more towards like the advantages of hospice, just because,
Mhm.
like we talked about, you have the advantage of your patient being somewhere where they want to be and in a more conducive environment, if possible, versus in a hospital setting and things like that. So, what
So
if
I
you?
guess, if you want to consider this a drawback, is that they can't seek aggressive treatment for their disease process that we have them admitted for testing. So say it's a cardiac diagnosis, they can't go get heart caths and, echoes and all of the aggressive heart testing and stuff. But if they've come to the determination that, the doctors told them there's no more treatment options, why do you need to keep going through that testing anyway? You know, it's there. It's not necessarily going to change it, or it's only going to get worse. And, cancer patients, for so long through their cancer treatment, they've had PET scans and MRIs, and they're used to getting these and getting updates in the status of. And so sometimes cancer patients have a hard time with that because it's like, well, I need to get my PET scan. I need to know what's going on with it. So those are things that they can't do while they're on hospice. But I think the benefits of the hospice so far outweigh that kind of thing, especially when it's determined that there are no further treatment options available. Um, you know, and I've had patients that it's like, I've asked physicians, okay, if they don't do treatment versus they do treatment, what's the difference in the life expectancy? And usually it's a matter of a couple of weeks. It's really not. But if they do treatment, they're going to be sick and their quality of life is not going to be there. Where if they forego treatment, they may have a better quality of life, and they may not live, they may live a week or so less, but those last weeks that they have is a more quality of life. So another, I think sometimes misconception with hospice is that they have to be homebound. A hospice patient does not have to be homebound. So if they're having a good day and they want to go, fishing, or they want to go to the casino, or they want to go shopping, or whatever they, like to do, we encourage that. We want them to do those things on the days that they feel good. Obviously not overdo it and, exhaust themselves totally, but if they have a good day and they want to do something, we want them to do that and have that quality of life and make those memories with their loved ones for sure.
In the same vein, like these are also, I would say 9 times out of 10, these are those patients that they've gone through this illness, or they've gone through with this condition for so long that
Mhm.
I've had these patients that they're just like, I'm just tired. I'm tired of,
Yep.
having to do this. And not just in their perspective, but also that I've had them tell me, like, I'm tired of putting my family through this. Like, I'm
Mhm.
tired and my family doesn't deserve this anymore. And it's hard, but I mean, I could see it. I
Yeah.
If it was me and I've gone through years of, treatments and then remission and then treatments, remission, like I don't know. And like you said, it's not that hospice is saying that they're giving up on the patient. It's just giving them a
A
better
different focus.
quality.
Yep.
Yes, 100%.
Yep.
Um, do you have any, like, what's a story where one of your hospice patients or one of your family members in hospice, like that have their family member in hospice, um, like what's like a success story for you, or what's been a moment where it's like like we have them where it's, wow, this makes the job worth it. What would be
Mhm.
that story for you?
Um, I have so many from the years of doing hospice, but one that I like to tell, she was a younger patient. She was 56. She had leukemia. And I went into the hospital to do the information visit to explain to her and her son and daughter-in-law, the options of hospice. And so the son, Junior, had to go to work, and she was like, well, let's tell Junior about it real quick and let him go. So we said, okay. So I kind of did a quick spiel, answered any questions he had, and he had to get out the door. So we start going through and signing the paperwork, and we get to the DNR. And at first she said, oh no, I want to have CPR done. And I said, are you sure? And I kind of did my little spiel of, well, it's not like on TV. They don't go poof, poof, and your heart starts beating again. And so the daughter-in-law says, "Oh, wait, wait, wait. We got to call Junior and tell him before she's, we got to make sure he's good with it." So we get on the phone, and the patient starts telling him, and she says like verbatim what I said. And I'm like, oh, she got it, like right there. It's like, oh my gosh, I love it. And then, but she was able to explain it to him too and tell him, this is my wishes and this is what I want. And he was able to say, okay, well, mom, if that's what you want, then I'm good with, I'll honor what you want, your wishes. And so she was able to, you know, have a more peaceful end of life experience. And that's what it's about. When you get these patients and families that are not accepting or in denial, or no one wants to lose their loved one, no one does. But at some point in time, everybody's going to pass. So it's giving them the education and the resources and the support to be able to say it's okay to go, and them have peace with it and the patient have peace with it. It's a beautiful thing. It really is.
Hands down. Yeah. And I mean, I don't want to say it this way, but like everybody dies.
Right.
So
Yeah.
yeah.
Unfortunately, they do, and we just, get to be there at that time and make it more peaceful and more comfortable for them.
And at the same time, it's the empowerment for the patient, for the family, but I would say even as the provider, being that patient advocate. And
Hmm.
that's, I don't know, for me, that's what I love. I love being able to like kind of stand in the gap for that patient when they're not able to express their wishes and stuff like that. Just kind of I don't know, especially with our elderly people, just kind of like
Yeah.
being there to say like, this is what they wanted. Even if they can't express it right now, this is what they wanted.
Right.
I love our little elderly patients. They're
Oh
my
no.
favorites. So, oh, Bobbie, that's all I got. If you want to add
Okay.
anything else
I
or
think we've pretty much covered everything. So, and I guess maybe I will add this for patients, families, don't be afraid to ask, is hospice an option for me now? It may not be right now. Or I know a lot of times families will call and want hospice, and, we'll gladly go out and do an information visit and answer questions and, provide information and guidance. And then, like I said, of course, we have to have the physician's order, but it may not be that they're ready just yet, but we can kind of get a baseline of them. And then as they decline, and tell them what to look for, like as they decline, if this happens and this happens, then they may be more appropriate for hospice at that time. And not all of
absolutely.
our patients die on hospice. Sometimes we have to discharge patients. Sometimes they get better. Sometimes they improve. Sometimes it's we go in and take too good a care of them and get them too good, and they have to discharge. And that's not a lot or the norm, but occasionally that does happen. So,
I wouldn't
and
say
then,
that's a
but they don't,
loss, but
when we have to discharge them, though, the families don't like it. They don't want to give it up. So it's like, no, I don't want to give y'all up. I don't want to. But unfortunately, if they don't continue to decline and meet that criteria, then they can't stay on the services. So,
right. But it's still always an option in the back pocket.
right. So,
I
okay. Well,
I appreciate you, Miss Bobbie, and
okay.
thank you for your time. Thanks for the info. Definitely a lot of
All right.
things to dispel about what people think hospice is. So,
All right. Okay.
um,
Thank you.
oh, absolutely. And as I end every episode, so with that.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.